Benzodiazepines are by far the most common drug that we use. Almost every case is now starts with a benzodiazepine. Okay? So there's extensive clinical uses. We'll talk about the structure-activity relationships, mechanisms of action, side effects. Then we'll go into specific drugs. I'll really concentrate on midazolam because that's a major drug that we use. And then we'll talk briefly about diazepam. Diazepam is considered the grandfather of this group. Okay? That's the initial drug that everybody began to use, also known as Valium. And then what we use now in the intensive care units, because it's cheaper, long-acting, more responsive, which is lorazepam, also known as Ativan. And then we'll also talk very briefly about some anti-insomnia medications, which the author threw into the chapter. I personally don't use anti-insomnia medications in any of my patients. It's too unpredictable. I instead use IV medications that are something that I know are going to come on and off. But it's kind of good to know about the anti-insomnic medications just because a lot of people do take them. Then we'll talk about the reversal agents for benzodiazepines, which is flumazenil. The pharmacological effects of benzodiazepines is they have some very important abilities. First of all, they're antegrade amnestics. They're not retrograde, they're antegrade. Okay? In other words, if you have a memory of something, it's not going to take it away. But if you're going for surgery, as soon as somebody gives you Versed, you really can't form a memory at that point. So it's very helpful to prevent somebody from having memory of the operation. Okay? But if you have somebody who has not been given a benzodiazepine, and then they wake up in the middle of surgery, and then after that you realize that the person is awake, and you give them Versed, will they not remember it? And the answer is they still may remember it, because it's not a retrograde amnestic, it's an antegrade. Okay? The actual amnesia lasts longer than sedation, which is kind of strange. That means a person could be talking to you, and they'll have a whole conversation with you, and they'll act like the funniest person. You know, they'll tell you some things that they would not normally tell you, and then they won't even realize that they told you it. I had a lady the other day. We put her to sleep, and actually last night, and we did. She had stones, very severe, and at the end of the case, she told me, says, "Please don't tell him what's on my back." And I'm going like, okay. We flipped her over, flipped her back on, and then she tells me, says, "You know what's on my back?" And I goes like, "You told me not to say." "Well, it says delicious." I'm going like, okay, all right. So the whole room started, of course, erupted in laughter like you guys did. So much for her not wanting to know anything, wanting anybody to know. She had definitely gotten some Versed beforehand. So good. It is a sedative. It takes your anxiety away, which is kind of nice. And you can really relax people. But really, what makes people relax better than benzodiazepines is your presence. They've actually showed in a study that if you walk into a room and you show confidence and you feel and people trust you right away, that their anxiety drops off a lot. Okay? It's nothing worse than having somebody come into the room and going, "Huh, how you doing today? This is my first anesthetic of my life." It's like, great. That'll make my anxiety go through the roof. Okay? Or you tell the attending, "Dr. Nolan, I've never intubated in front of the patient." And when a student does that, I look at him and say, "Guess what?" And he goes, "What?" "You're not doing one either today." And he goes, "Oh." And I tell the patient, "I'll be doing the intubation today." And I've done many. Okay? And so don't do that in front of the patient, because then I have to give a lot of anxiolytics to make them relax again. Okay? So don't do that. Be professional. Always show confidence. I always can tell people that don't have confidence, and the way you know is when they do pediatrics. Kids smell fear. They're like fear sensors. So if they see you freaking, if you're nervous, then immediately the kid goes completely rabidly crazy. You know? And I remember the way I put kids to sleep is I don't try to smother them most of the time. I usually will hold their hand, we'll walk back, and kids will walk back, put them to sleep, put them on your lap, tell them to hold a mask, They go right to sleep, not a big deal. As soon as the student is a fade, the student keeps looking at the kid like, and you see your eyes are getting bigger as he's freaking out, like, uh-oh. Okay, so these drugs are very helpful for that. If you have a kid that's completely wired, benzodiazepines are also very good anxiolytics. Benzos also will terminate seizures. The limitation with them is they don't take EEG activity to zero. And the other thing is that if you're using certain agents, some of them are so short-acting that the seizures will start up again. I had one person that kept going in and out of seizures, and they kept giving Versed, okay, to stop the seizures. And I kept looking at them like, this is great, guys, but guess what's going to happen in 5.5 minutes? Seizures start back up. It's like the duration of action is too short, okay? So we switched over to Valium and terminated it and stopped it at that point. Then you add, of course, the other anticonvulsant on board as well. Spinal cord mediated skeletal muscle relaxation also takes place. And that's actually a very important thing. We used to, one of the treatments in the ICU for tetanus is giving high doses of Valium IV. But it's really not adequate for muscle relaxation for surgical procedures. And it doesn't diminish the neuromuscular dosing at all. So it works in the spinal cord, but it does not work enough to cause muscle relaxation like you would expect for surgical procedures. It's really the ideal preoperative medication. So benzodiazepines have now replaced barbiturates as the actual pre-medication of choice. Compared to barbiturates, there's less tendency to produce tolerance, there's less potential for abuse, so they're less addicting than opiates, cocaine, and amphetamine, and barbiturates. But trust me, they're still abused. Any medication will be abused if it alters your sensorium. So as long as you take enough of it, you can cause yourself problems. It is very safe in overdose situations because as long as you treat the cardiovascular system and give the person oxygen, patients recover fine. The downside to it is if you're not on top of it, the person will go apneic and die from hypercarbia and hypoxemia, mostly from hypoxemia. It does have fewer or less serious drug interactions, especially midazolam, and it does not induce hepatic microsomal 1 enzyme. So benzodiazepines don't crank up your P450, which is kind of neat. Now, what's your structure-activity relationship? Okay? Basically, there's 3 components to all benzodiazepines. You have A, which is a benzene ring. The benzene ring, of course, is a 6-carbon chain, a cyclic chain that's got double bonds in it. Okay? Then you have a very unique structure, which is B, which is called the 7-membered 1,4-diazepine ring. The 1,4 has to do with where the nitrogen is at. Okay, so that's where your nitrogen is at, 1,4-diazepine ring. And then you have attached to it in C what's called the aryl substitute. The aryl substitute, when you put this all together, the benzodiazepines are called 5-aryl-1,4-benzodiazepine. That's the major structure that all benzodiazepines originate from. Okay? And we'll go into how we actually alter them. And we'll talk about how midazolam can go from a closed chain to an open ring configuration that makes it either water-soluble or water-insoluble. Okay? And that's kind of important. And they actually asked that on the boards apparently this week. So I was impressed. So I had already been making up the slide, so I know that you guys hadn't received that before, so now hopefully this will help you guys. Now what benzodiazepines are is that they're very, very, very high lipid solubility. Okay? So that means they go into the brain very quickly. Now which one goes faster, pentothal, which is a barbiturate, or benzodiazepines into the brain? Pentothal. Pentothal works faster. It's a more rapid induction, much smoother induction than benzodiazepines. Okay? But still, they're pretty quick. They're also highly protein bound, so if you, just like benzodiazepines, if you drop your albumin level, you can have a much profound effect on that person. So if you have hypoalbuminemia, it leads to less binding of benzodiazepines, and it causes a significant enhanced clinical effect. You see that again for the same reasons: hepatic cirrhosis, chronic renal failure with protein spillage. The nice thing about benzodiazepines is they're very well orally absorbed, and also they can be used rectally as well. We do that in kids. We can put them to sleep with benzodiazepines as well that way. And also what's beneficial is that IV benzos can also be used very effectively. Midazolam specifically is very, very good IV-wise. Okay? It causes very little pain on injection. Can you still feel it? Yes, but it doesn't cause as much pain. Diazepam, on the other hand, because it's got a carrier, propylene glycol, it causes a lot of pain when you inject it. Versus midazolam doesn't need to have that carrier because it stays water-soluble until it enters your bloodstream, and it converts into a lipid-soluble agent at that point. But it's a much more effective IV agent. It enters the brain rapidly when you inject it IV, and also enters also other vessel-rich groups that are soluble. The mechanisms of action is very simple, very similar to barbiturates. It binds to the GABA receptor again. So it binds and basically opens the chloride channels, increases chloride conduction, and hyperpolarizes the postsynaptic cell membrane, and makes the postsynaptic neurons more resistant to excitation. We already talked about that. Same picture. So sort of again to re-enhance that you're binding to the same kind of receptors. So one of the things that I want you to really understand is that when you're putting people to sleep, you're using the same mechanism. You're just using different classes of drugs to put this person to sleep because it has different binding sites on this GABA receptor site. Okay? And when you're giving propofol, it also works here as well. So all our induction agents are working on GABA sites because they put people to sleep very rapidly. We've just figured out better drugs chemically to give that work on the same site. The GABA receptor actually is a large macromolecule. It's a 5-protein component. Okay, it's got 2 alpha. It's got a beta and a gamma group. Okay, we'll show you that in a minute. And it can actually bind to different receptors in different locations. So GABA is not just it's not binding to only one site. It's actually binding to more than one site. Okay. You can actually have specific benzodiazepine receptors. You have barbiturate receptors. You have alcohol receptors. Etomidate, propofol, and also steroids will also bind to GABA sites. It can produce significant synergistic effects. So that means if you add all 3 of these together, let's say I add a barbiturate, alcohol, and then I add a benzodiazepine, well, that makes it almost a lethal combination. Every time you add a new drug, it adds more potency to the GABA agonist activity. Okay? Remember, it's not an antagonist, it's an agonist. And basically can increase the risk of overdose. Most people die from benzodiazepine or barbiturate overdose because they're drinking alcohol. They're drinking, and their alcohol binds to the same site and acts synergistically. So that's how most deaths occur. Basis for benzodiazepine as first choice for the alcohol detoxification, because as alcohol begins to come off, the benzodiazepine some of you can give to a person so that it prevents them from going into delirium tremens and stuff like that. The GABA receptors here, I want you to look at. Okay, you have 2 alpha sites. The alpha subunits we'll talk about that are slightly different. You also have 2 beta sites. Beta is where the GABA actually binds to. Okay, beta 1 and both the beta 1s is where the GABA, the endogenous neurotransmitter, binds to. Okay, and then you have the gamma site. Now the GABA subunits, the alpha 1s, have recently been found to come as 2 forms of subunits, which means you can take the alpha subunit out and replace it by genetically different subtypes. They're actually doing work on rats now to figure this out and how you can actually identify different subunits. Why is that important? Well, if you give somebody a GABA selective alpha 1 subunit medication, it gives you sedation, okay? Versus if you want just anxiolysis, you can give, if you can find a drug that's selective only to alpha 2 subunits, it gives you only anxiolysis without all the respiratory depression effects. Pretty good, okay? Now, GABA alpha 1 subunits are the most abundant. They're found in the cerebral cortex and the thalamus. And the one that controls your memory, which is a GABA 2, alpha 2 subunits, are located mostly in the hippocampus and the amygdala, which is controlling your memory. So not only are you going to cause anxiolysis, but you're going to form also amnesia. for that person. The areas of the brain thought to be most involved in memory have the highest concentrations of GABA receptors. Okay? So this is actually the actual protein structure, showing you that each site has a different affinity to different medications. You can see the alpha sites tend to be sensitive to propofol, etomidate. Okay? Benzodiazepines seem to also bind to the alpha sites as well. GABA binds only to beta sites, and barbiturates also bind in between the beta sites as well, and alpha sites. This is the actual area. I got this the other day by pulling up a research article where the highest concentrations are of the actual GABA receptors in the brain. It shows you this in the frontal cortex. It's also showing you this in the thalamic areas, and it's also in the cerebellum. Benzodiazepines on the effects on the EEG. Benzos affect the EEG seem to be similar to barbiturates, but they do not cause EEG, isoelectric EEG activity. So they cannot cause you to go isoelectric, not like barbiturates can. Okay, so they have a ceiling effect. The tolerance to the effects on the EEG do not occur in benzo as it does with barbiturates. You don't get the tolerance. The effects of benzodiazepines on reticular activity is important due to this area of the brain affects wakefulness, and that's what causes sedation. This is the actual, again, the picture of the receptor. I'll just go back. This is the receptor looking at it sideways, and this is the image of it from above. So you can see the chloride channel in the middle. This is the chloride channel in the middle. And these are the different subunits that you have. There's just 5 protein subunits. And they're actually beginning to map it to see where the binding sites are taking place, okay, which is kind of interesting. You can see that the GABA sites are located pretty much at the beta sites, and then you also see other things like neurosteroids and barbiturates can sometimes bind not only the beta sites, but also in the barbiturates seem to bind also in the gamma sites. Okay, so we still got some things to learn still. We're still learning stuff. Depends on how you talk about it. GABA is when you say GABA, it's actually a neurotransmitter. But the GABA receptor is where the neurotransmitter binds to normally. Other stuff bind to it, of course.
So technically, if you said
well, you should specify if you're talking about the GABA, the neurotransmitter, or the GABA receptor. That's really the proper terminology.
and we've been talking about
GABA receptor is what we've been talking about. Okay? All right. Now, as we've been doing this discussion before, okay, what I've been talking about is only the GABA receptor. I'm not talking about GABA, the molecule itself. Okay? We're talking only about the actual receptor, which has the different components to it. Now, let's go on to the next discussion, which is side effects. One of the side effects is that you get fatigue and drowsiness is the most common side effect in patients that are chronically treated with benzodiazepines. And sedation that impedes performance usually can actually still be present for up to 2 weeks if you're on chronic benzodiazepine therapy. Benzodiazepines do not affect ventilation if they're used in lower doses, but still could cause you to go apneic if you give it in high enough amounts or use it synergistically with other agents. Okay, so benzodiazepines actually have a pretty good safety profile, but still, a lot of people see this in writing where it says it really does not affect ventilation, and that's really not true. Not when you combine it with a lot of other agents, which is, of course, polypharmacy is a common issue in the normal world and even in the OR. Okay? Benzodiazepines can cause impairment of motor function and cognitive impairment, so you really shouldn't be driving when you're on benzodiazepines. That's why we don't allow people, after they've been giving a benzodiazepine like Versed, to be able to drive immediately afterwards. They're still wide awake, appear to be normal, but their actual psychomotor functions are impaired, and they can actually make a mistake and just drive in front of a Mack truck, which of course would not have a good outcome. Acute administration can cause also transient anterograde amnesia, especially in the presence of alcohol. I had one patient that came back 5 days after surgery and said he was in our anesthesia department because we did not administer anesthesia to him. And I looked at him and said, well, pull up your shirt, sir. And because I knew the guy, actually I was the one that took care of him. He didn't even remember me. So he said, he pulled up his shirt, and he's got this big incision. And I said, well, how do you think that got there? And he says, do you remember that at all? And he goes, no, and that's the point. You didn't do your job. And I said, oh, okay. We gave you a medication that made you stop having a memory. So that's why you don't remember anything. Do you remember anything in the hospital? And the guy goes, nope, I don't remember anything in the hospital I don't remember being in the hospital at all. All I remember is I woke up in my house, which was 3 days post-op, and I had this big scar. I didn't understand what the hell happened. And he actually gotten 5 milligrams of Versed, and he was 85 years old. And that's why. They basically had given him antegrade amnesia for 3 days. Pretty impressive stuff. So be careful with when you give this stuff to people, it can really cause some problems. It will suppress the hypothalamic pituitary adrenal axis. Okay? You also can get dependence, and then you will also get withdrawal symptoms when you stop these medications, including insomnia, agitation, and shakiness, which is tremulousness. Aging in the liver can affect glucuronidation, less than oxidation, so these people then don't metabolize, and you can't get rid of this medication, so it stays on board for long periods of time. Things like diazepam and triazolam are metabolized by oxidation and should therefore be used in caution with these patients because it has prolonged effects. Diazepam, if you think Versed bad, diazepam is like the nightmare in elderly. You give somebody Valium, you could lose a week. These people will remember nothing for about a week. So it's something I don't give people Valium or diazepam in the elderly. Now, midazolam. There's a secret to every medication in their wording. Okay? If you look at midazolam, the actual wording, midazole, okay, comes from the actual chemical structure which makes midazolam unique as a benzodiazepine. Midazolam, you put an I in front of it, is an imidazole group. So it has an imidazole ring in its part of its structure. This structure up here in the green box, okay, is the imidazole ring. Okay, it has the 2 nitrogen components in it. This confers in it a nice water solubility. Okay? So it accounts for the drug stability in aqueous solutions. So you can actually use benzodiazepine, like Versed, in a vial, and it stays in solution. Pretty nice. Okay? Versus all the barbiturates, you really can't do that to them. They have to be in crystallized form, and then we have to be reconstituted prior to using. Midazolam is unique because it's a water-soluble benzodiazepine. It does not need a carrier, and its consequence doesn't cause pain when you inject it. The indications that we use Versed is many. Okay? It is the most common benzodiazepine that we use. It's used extensively for preoperative medications. It's also used for conscious sedation. It's a great anesthetic induction agent for hearts, especially, wherein you expect the person to be a prolonged ICU stay. It's also very helpful as a maintenance agent when you can add it to other agents. If you think somebody's not really deep enough, but they're not really tolerating the volatile anesthetic, you can add Versed to make sure that they're amnestic. And also, it's a very good anticonvulsant. The downside to the anticonvulsant is that it doesn't last long enough, and the person can re-seize on you. Midazolam has 2 to 3 times more potent than diazepam, so it has a very high potency rate, and it has twice the affinity for the benzodiazepine site compared to diazepam. Midazolam also comes in this is how it's coming now in our clinical sites. I'm used to seeing it like this. It's now coming like this, which is kind of nice because now you can peel it off and use that as your labeling. The pKa of pH is around 6.15, and salts are very water soluble. Okay? If you look at the actual buffered solution, it's actually at a pH of 3.5, and you'll see that the actual midazolam has a ring structure that stays open below a pH of 4, thus maintaining water solubility. So if you see this one over here, this is midazolam, okay, in the open ring structure form. This area is where you'd have, this is what the actual exo boards. They ask, where is the midazolam? How does it stay water soluble? Okay, And the answer is in the ring structure at a low pH of 3.5, which is what you're making the solution up, and that's what stays at water soluble, the ring structure is open. Okay? So that's where you would tab it. The picture, they're actually giving the picture of the molecule, and then they're asking you to say where is it that it opens. So you know, and if you put it in this area here, that it opens here, you would get the correct answer. All right? The nitrogen peels away and opens up. Now, when you inject this medication IV, as soon as it enters your bloodstream, the pH converts back to 7.40. And it drives the ring to close. So you go from a water-soluble agent now into a lipid-soluble agent, okay, which has to bind to proteins right away to be carried. And no longer will stay suspended in your bloodstream. Now, does it tolerate, I mean, what does that crystallize as soon as you give it into lactated ringers? The answer is no. It has to hit into your bloodstream before this medication converts into the closed structure and becomes lipid soluble. Very important question. Okay, so expect that I'm going to ask the same question. So I want you guys to know it for the test. Okay, so when you get to your boards, you'll know what the structure looks like. So I'll give you a structure like this and tell you where is it that where's the open structure. Okay? Now, the non-solubilized agents such as propylene glycol is not necessary for midazolam, which is propylene glycol is really irritant to the vein. And that's why diazepam, when you give it IV or IM, it's really painful. And that's why we don't like giving it that way. We like giving it orally instead. IV does not cause venous irritation, compatible with lactated ringers and normal saline, can be mixed with acidic salts and other drugs such as opiates and anticholinergics. You don't get any crystallization with it. Great drug. Okay? It's almost compatible with almost everything. It can also be given IM. Of course, a needle is what causes you discomfort, but the injection of the medication doesn't, and has also pretty rapid absorption. Where you also see midazolam given is PO for kids. We do that a lot. We give them medication to swallow. The downside to it is midazolam is very, very bitter. Okay? It does not taste good. So you usually have to mix it with something that's really, really sweet. So what we usually do is we mix it with Tylenol, with a cherry Tylenol. So it's got two effects. You're getting Tylenol as an anti-inflammatory agent, and then you're adding the benzodiazepine in there, which is midazolam, to that, so you get the effect that you want, which is sedation and anxiolysis. You can also give it nasally to kids. I've seen it done. Most kids hate you after that because it burns so much. But I've seen it also stop seizures in children via the nasal route. And actually works really, really fast. When you can't get an IV started, you just drip it into the nasal area, and it's almost immediately absorbed, and the seizure terminates. They're actually showing that to families to stop their kids from seizing, and it's pretty safe because it doesn't cause you stop breathing at that point. The other one that's also, which I spelled wrong, I'm sorry, was buccal. I spelled it right in another area. Buccal was they put it in the mouth and actually drip it inside the side of the tongue, and actually works at very rapid absorption as well. So the children dose that we actually give for sedation is 0.5 milligrams per kilo. I'm not a real fan of this high dose. I go with usually 0.2 to 0.3. So I'm usually much more conservative. I'd rather deal with a kid that's a little bit kind of just sloppy but not completely out. The 0.5 milligrams per kilo, I've seen kids, my daughter got it when she had strabismus surgery, and they gave her 0.5 milligrams per kilo, and she went apneic. And thank God I was in the room because everybody left. Everybody just said, I'm just going to give this kid PO, 0.5 milligrams of Versed. I'm looking around like, what the hell are these kids still doing? You know, that's something I would never do. So my daughter started getting really sleepy. I put her on the bed, and pretty soon she was out. So I started doing a jaw thrust. I called the nurses, hey, you want to give me a little hand in here? You know? And they pretty much freaked out at that point. They looked at me like, what? I said, you want to get a pulse oximeter on her, make sure she's okay? I was getting ready to do mouth-to-mouth, okay? But had it not been there, she would have been dead. So that's an important learning point. Never, never, never walk away from somebody you sedate, because you never know what the effects are going to be. Some people are really sensitive. Other people are not. Okay? It depends on their parents around them, too. If your parents smoke or they're giving you food that contains different material, you can be very sensitized or desensitized to the medication versus other people. It's like some you know what the treatment of a sore throat was in the old days, and when teeth would hurt, you know what people would do? Not the cocaine, but more liquor. They would give you what's it called? Bourbon. They would give you bourbon, or they would give you cognac in your mouth, and they would take away the pain. But now, what happens to the kid exposed to alcohol at that age? What do you think happens to their P450 system? It cranks. Okay, so when it cranks, when you give these kids Versed, they're going like, yep, no problem. It doesn't have an effect. Versus you have a kid that's completely clean, never done anything, never been exposed to the same, parents don't smoke, nothing's around them. They go down like a ton of rocks. Okay, so be careful. Usually 30 minutes before induction is when you give the PO dose. You got to be patient. It doesn't happen right away. It does take about 30 minutes. It gives you very good sedation, anxiolysis. It gives you great anterograde amnesia, and does not really produce delayed awakening in most cases. You can, of course, give it parenterally, which is IM. Then you have to drop your dosage way down to 0.05 to 0.1 milligrams per kilo. I'd recommend you go to the lower doses. But most kids do not like the idea of being punched with a needle, you know. There is a trick to it, if you ever want to learn it. And what you do with the kid is you get somebody to slap his arm on the opposite side, and then you hit him on the other leg when they're not noticing. And they go like, what just happened, you know? And they don't know which one to cry about. And then they look at you like, that was bad, okay? And then they go, poof, okay? So it works, okay? And you get a lot. But if they watch you putting the needle in them, they really freak. So it's really more effective to get somebody to slap them on the other side. They look at him like, and then you hit them on the other side, and they go, what happened? And then you're done, okay? So it does work. Some people actually add scopolamine to it, but it's really synergistic, so be careful. You get profound amnesia and analgesia. And the other thing that's bad about scopolamine, it really can dry you out and make people pretty uncomfortable. Adults, I give 1 to 2.5 milligrams IV. That's all I give. My rule is don't give above 2 milligrams. Anybody. Nobody deserves more than 2 milligrams. Unless you got somebody who's on benzodiazepines at home and is a truly crazy person and normally and just hyper anxiety person, then you may go up to all the way up to 5 milligrams. But really 99% of the cases you should do should be less than 2 milligrams. Really stay down below that. The first recommended dose of midazolam was 5 to 10 milligrams IV. And I can personally tell you that we would give 5 milligrams IV of Versed to 80-year-olds. And they would do this. Wake up! Breathe! Okay? And they wouldn't breathe. They go apneic on you. It was really scary. Okay? So be very, very careful with older people on Versed. It is unpredictable. So anybody over 75, I only give 1 milligram. That's my limit. Nurses always look at me like, sure, Dr. Nolan, I could have the other one. It's like, nope, just give 0.5, okay? Because sometimes 0.5 is enough, okay? So this stuff goes a long way in the elderly. Remember, brain mass matters, okay? So less brain mass, less brain receptors, more potency of the agent. Time to complete recovery is not shorter with midazolam, unfortunately. The effect side equilibration of midazolam must be taken into consideration prior to giving any subsequent doses because it will accumulate on you as well. Okay? Now, synergistic actions it also takes place when you add opiates or propofol. This is something that makes this drug very, very dangerous. Okay? Everybody forgets this, and when you read this in a textbook, you go, what the hell is synergistic action? What does that mean? Okay, well, here's what it means. I'll give you a clinical example. Okay, I had a guy we were doing a cysto on, and the patient was kind of an anxious guy, you know. We put a spinal in him. We gave him 2 milligrams of Versed, and, you know, we were doing 30 minutes in the case. The guy's fine. He's not having any pain, but he's getting really anxious, okay? So he keeps telling me, he says, you know, it's like everything's uncomfortable. My back's hurting. I don't like this position. Can you give me something more? So I gave him 1 cc of fentanyl. Okay, get him a little bit more comfortable. Take away some of the discomfort from the position, okay? That seemed to work pretty well. And then he says, it's like, I'm still uncomfortable. Can you make something? And the surgeon's now saying, keep the guy still. So I said, well, geez, I don't want to give a lot of Versed because now it's going to accumulate. I'm already up to 4 milligrams already in this guy, and I got 50 mics of fentanyl. I give another dose of fentanyl, but nah, I'm going to give something short-acting. I'm going to give something that I know is short-acting, predictable, it comes off fast, and I'm going to give propofol. So I just said, okay, I'm going to test this out. 20 milligrams, 2 cc's. That shouldn't have any effect. The minimal, nothing. Should be easy. Yeah, wrong. As soon as I gave the 20 milligrams, as soon as it circulated, 45 seconds later, the guy is no longer breathing. He is definitely no longer moving. Okay? But the biggest thing is he's no longer breathing. And I'm freaking. I'm going, come on, dude, breathe. So I'm lifting up his airway. He won't breathe. Do a jaw thrust. He won't breathe. And, of course, the attending down the bottom, surgeon's looking above. Hey, man, I love this. He ain't moving anymore. So I start freaking because now I'm a little intern. I was told just to sedate the patient, and here I'm killing the patient by giving them propofol because I remember reading the synergistic action, but I didn't know what that meant. Guess what? I found out what it meant. So I immediately slapped on the mask, started ventilating, and thank God I could do one thing. I could actually ventilate. Okay? So, and I kept that guy ventilated for 15 minutes before he started breathing again. So that is not the way propofol is supposed to work. Propofol should only work at 20 milligram dosages for about 3 to 4 minutes before the person stops breathing again. This guy took 15 minutes to recover from one single dose. So what do you think I gave him? Do you think I gave him any more Diprovan after that? Heck no. And then he started waking up, moving around. I told the surgeon, said, guess what? You're on your own, buddy. And I'm not doing this anymore, this guy. And it almost killed him for about 15 minutes. So you'll learn your thing. In our days, we didn't have radios. So the only way you get told you're attending was you had to beat the attending, which by the time that took place, it took 5 minutes before the attending ran around to come and help you. So you better be able to ventilate for those 5 minutes. Or otherwise, you just hit the blue button. Code, okay? So try to avoid that, of course. Okay? But that's why you have radios, so you can ask for help immediately if something like that happens. But that's what synergistic action does. What you can also have is prolonged psychomotor impairment after conscious sedation. It's a little bit less likely with midazolam, even when combined with other drugs. It does have significant synergistic actions in regards to ventilation and oxygenation. So you better be aware of that and be prepared to be able to ventilate somebody. Never take a conscious sedation patient and start mixing 3 different drugs, especially drugs that start binding to the same receptor. That's why you don't give Diprovan and Versed together and expect to have the same response. You're going to get a doubling or tripling effect sometimes than you should expect. Induction-wise, great induction drug. Okay, I use this quite a bit in open hearts. It is the primary induction way to put people to sleep for heart surgery. We're giving usually 1.1 milligrams per kilo. So if it's a 100 kilogram patient, you're giving 10 milligrams IV. So that's a pretty big syringe of Versed. And most people go to sleep very smoothly in about 30 to 60 seconds. Thiopental it's right at 30 seconds. Diprovan takes around 40 seconds, and Versed usually is around 50 to 60 seconds. They say 30 seconds, but I think that's in somebody with a high cardiac output rate. It's really going to take about a minute before the person goes to sleep. So it's not the ideal drug to use for rapid sequence. It is not a good rapid sequence drug. Okay? It's a great drug for somebody who you know has not got a full stomach, that you want to get a smooth induction in. It gives you a very smooth induction profile, but it does take a little longer than propofol or thiopental. It is 50 to 100 times faster with thiopental when you give that. More gradual cardiac and respiratory effects because it is a little slower. It tends to give you a much more smoother induction. I've had one time where we actually gave 0.2 milligrams of Versed to somebody, and they were looking at us like, what are you doing? Okay, so the first thing you check is what? Check your IV. I checked the IV. The IV is functioning fine. So I said, okay, let's give another 0.1, another 10 milligrams to this guy. He's looking at me like, geez, doc, don't you want to give something a little more powerful than that? So we end up giving this guy 100 milligrams of Versed to put him to sleep. I kept running out of vials to probably knock him out. This was for heart surgery. So the guy was drinking a fifth of vodka a day. He was a little bit driven up, okay? So we should have just switched agents, is what we should have done. What was even more impressive is the guy woke up very promptly afterwards, even after 500 milligrams of Versed, which we ended up giving, which is a huge amount, okay? That's something you normally would never do. And this guy woke up like, it was like, no big deal. You have a decreased time of onset of action. So adding a small amount of opiate ahead of time will really enhance the effects and put people to sleep much more smoothly. So usually you give the opiates about 1 to 3 minutes prior to giving midazolam if you're doing this kind of induction. And we usually do this for hearts. We usually mix it up front. We give fentanyl a little bit, and then we add Versed, and then we keep adding the Versed till the person falls asleep. Once the person's asleep, we add the higher dose of fentanyl followed by Pavilon, and that's our normal cardiac induction. To decrease the induction dosage, patients who receive preoperative CNS depressants, such as they're on alcohol or they're elderly, you have to decrease your dosage. And you increase your dosage in younger patients or patients that are on long-term benzodiazepines or on other kinds of drugs like chronic alcohol therapy. Maintenance anesthesia with midazolam can be given to supplement opiates, propofol, and inhalational agents. The only thing I'm really weary about doing this is that it doesn't give you a context-sensitive time that you would expect. So sometimes you get accumulation with this drug. So you got to be a little careful. Don't go crazy with Versed. Where we would give Versed a lot would be on your induction for open heart surgery, and then 10 minutes before you're coming off pulmonary bypass, we would give 4 to 5 milligrams more of Versed right at that point. So make sure that as you start rewarming, the brain stays asleep and stays amnestic. Okay? So in that sense, it's pretty good. But you do have the context-sensitive half-time increases with increasing duration of a continuous infusion, so it's not something you want to do. Awakening after general anesthesia with midazolam is 1 to 2.5 times longer than when you use thiopental. Okay? So it does have accumulative effects as a consequence. Maintenance, you have gradual awakening that receives the midazolam is rarely associated with nausea, vomiting, and emergence excitement, which is kind of a nice thing if you're working in outpatients. You're giving a little bit of Versed. It kind of helps you smooth that person's awakening on you. 1 hour after surgery, patients are equally awake with midazolam as compared with thiopental. So that gives you a very nice profile. Midazolam can be, of course, given PO, which is rapidly absorbed from the GI tract. It has extensive first-pass effect, which literally 50% of what you give PO is broken down before it gets into the systemic circulation. But once it gets into your left ventricle and eventually pumps it out to the vessel-rich group, which is the brain, it promptly crosses the blood-brain barrier because it is very lipid-soluble. The actual site equilibration time is a little bit slower than you expect, which is 0.9 to 5.6 minutes. So, but once it gets in, it does give prompt passage into the brain. But it just seems to take a little longer for this medication to take place. Propofol and thiopental are much better induction agents for rapid sequence. These are much faster in inductions. Okay, they're much more predictable in putting people to sleep. I don't like putting people to sleep with midazolam because I've had people, like I said to you, that took 500 milligrams before they actually fell asleep. That's a huge difference versus I give propofol to everybody and everybody's out. And if I want to give somebody an induction dose so they're asleep when I'm intubating them, I want to give something that's predictable as an induction agent. Okay? So midazolam is one of those agents when you give it, you watch the response. Okay? And then once they're asleep, then you give the muscle relaxant and then you continue doing your induction. Versus you can give etomidate, Diprovan, and sodium thiopental and methotrexate and get a predictable induction. The person will be asleep every time. I've never seen anybody beat thiopental. I've seen them, they say they try. I had one guy that was a pharmacist, and he says, I bet you I can beat thiopental. I started laughing at him. I said, okay, sure. And I put the mask on and says, okay, count. And he says, oh, I'll make it to 100. I said, yeah. Started counting as fast as he could. He made it to 30. Okay, that's how fast he got down. Okay, so much for being this big, strong guy. You know, this stuff is just amazing. You know, I used to box when I was a kid and used to fight quite a bit. And knocking out somebody was pretty hard. And to see one drug that's in the vial give somebody and they go down like a rock was like impressive. It was like, wow, this is a drug that I like to see. This is what got me interested in doing anesthesia. So benzodiazepines don't work like that. They're much more slow in onset. The good thing about it is the toxicity of it, which is the respiratory depression, can take a while to present. And that's what people get into danger with. They think these drugs are perfectly safe, and then they give it to somebody like a kid, and then they walk away, and then all of a sudden they got a problem. Okay? So don't be understand that your equilibration time takes longer. So what does that mean? The respiratory depression takes longer to show up. Okay? These drugs are all highly lipid soluble, and because of that, they're extensively bound to plasma proteins. Redistribution is, it has a rapid redistribution, very so much like, so all the benzos and the barbiturates are rapid redistributing drugs. The brain goes to inactive sites, which is the muscle and fat. And the CNS effects of midazolam are shorter than diazepam because it's more lipid soluble. The context-sensitive half-time is a little bit lower for midazolam in comparison to diazepam and lorazepam, which can accumulate more rapidly. The elimination half-time you're looking at for Versed or midazolam is 1 to 4 hours. It has rapid metabolism, which is much shorter than diazepam. You still get prolonged effect in elderly patients with the ones that have decreased hepatic blood flow, or even during after cardiopulmonary bypass, where you do have decreased hepatic blood flow as well. This medication gets metabolized based on the liver blood flow. The volume distribution of midazolam and diazepam are very similar. They both are lipid-soluble agents, so in consequence they distribute to the adipose tissue very well. And a lot of elderly people have a little bit more adipose tissue. Women tend to have a little bit extra subcutaneous fat than men, percentage-wise. So in consequence, these medications tend to go into their fat stores longer, and you can have a prolongation of effect in individuals that receive that. So you should be giving them lean body mass weight doses. Don't give them total body weight doses. It's not a good idea. I've seen people give somebody who is morbidly obese 10 milligrams IV of Versed based on their weight, just for pre-medication, and that was an induction dose. So don't do that kind of stuff. Okay? When you read the medications, make sure you understand the difference between lean body weight and total body weight. Clearance, midazolam is much higher than diazepam, which is a good thing. Midazolam undergoes extensive hydroxylation by a specific hepatic microsomal enzyme, which is P453A. It's not like the other benzodiazepines that are non-specific like that. Midazolam has a specific hepatic microsomal enzyme. Things that will inhibit P450 enzyme are erythromycin, fentanyl, and these will prolong the effects of midazolam. But the good thing is the H2 blockers like cimetidine don't have effects on the 3A. So they do not prolong the effects of midazolam. And this was a big issue in the old days because the only medication we had in the old days for H2 blockers before omeprazole came along was Tagamet, okay, which is what cimetidine is. H2 blockers do not affect the metabolism, and in comparison to diazepam gets very prolonged in its action when you give Tagamet to that individual. Overall hepatic clearance of midazolam is 5 times greater than lorazepam and 10 times greater than diazepam. So it really is cleared very quickly by the liver. The actual effects on the brain is that it decreases cerebral metabolic oxygen requirements, which is a good thing, but it has only a ceiling effect. Above a certain dose, you can't get any more suppression. And also what you get is you don't get a EEG, isoelectric EEG with benzodiazepines. It does decrease cerebral blood flow, and the ICP really remains unchanged. And you got to be really cautious with severely head-injured patients because you do suppress the ventilatory response, and you can get hypercarbic, and then the ICP will rise in those individuals. Okay? Cerebral vasomotor responsiveness to carbon dioxide is pretty much preserved, and midazolam like thiopental does not prevent increases in ICP associated with laryngoscopy. So it's really not a good agent if you're having a head-injured patient to use. So I never use midazolam as an induction agent for a head-injured patient. I usually would use in the past thiopental or propofol. Propofol predictably decreases your ICP, so it's a fairly good agent to use. Benzodiazepines have not been proven to have neuroprotective effects. Midazolam is a very potent anticonvulsant to treat status epilepticus, and usually give 5 milligrams IV, usually at that point, to 2.5 to all the way up to 15 milligrams IV. 15 milligrams IV, if you give that much, you better be ready to be ventilating the individual for a while. This kid's actually getting intranasal dosing of Versed to terminate a seizure. Works very effective. Okay, it's actually one of the things that they're doing in the emergency room now. The buccal administration is also what they have, which they have a Versed in a little, it looks like not a lozenge, but what's it look like? It's an aluminum foil it's a rectangle, and it's in actually a liquid state. You peel it open, and you drip it on the side of the kid's mouth, and it terminates its seizures within 3 minutes or less. So it also has a very good administrative protocol. Limitation of these drugs is that they're very short duration of action, which is part of the safety profile on it, because if you're going to go apneic with this, it's only for short periods, unless you have another drug on top of it, which makes it dangerous. But in a kid that's not really getting exposed to anything else except for this, it's a really good terminator. It has a ceiling effect and will not cause isoelectric EEG. What you'll see in pediatrics, you get prolonged sedation of infants with midazolam, and fentanyl is associated with development of encephalopathy. So you really should not be giving midazolam Versed to a kid in the ICU. You will have permanent encephalopathy that they don't recover from. We don't know the mechanism behind that. Okay? So it's really not a good idea. Okay? So stay away from midazolam and fentanyl together in the ICU. Or a kid comes from the ICU to you, you really shouldn't be doing this for prolonged periods of time. This is prolonged sedation. If you give it as a one-time dose, not a problem. But if you're giving it for days on end, you actually cause a neurodevelopmental failure in that individual. The other thing that happens with midazolam is that sometimes midazolam will cause a paradoxical excitement. You'll have people that will tell you, well, I get Versed, I go crazy. Truly believe that. Okay? It has to do with the receptor numbers. Okay? The genetics of different individuals have different receptor numbers. So what you see in these individuals is you get the inverse of agonism, you get hyperexcitation in these individuals. Okay? That's about 1% of individuals will have to get that effect. And what you want to do to terminate that anxiety is what? You give flumazenil. You reverse the effect. You push it back off. Okay? Because these people are getting anxiety from the medication. So give them flumazenil, reverse the effect, and all of a sudden they feel better. And that's why you have to be careful sometimes with midazolam. Midazolam effects on the ventilation is they produce a dose-dependent effect. Okay? This is really very serious. Do not, when you read the textbook, it almost seems like midazolam doesn't cause apnea. That is nothing but not true. It will cause apnea if you give enough of it. Okay? And you give it synergistically with other agents, you will get into apnea. Okay? So you have to be careful and understand that. It does decrease ventilation. It does decrease your swallowing reflex. It decreases your upper airway reactivity, so it increases your risk for aspiration. So if you have somebody who's somnolent already, and you just want to sedate them, and you give them Versed because you think it's safer than Diprovan, it's not safer. That person can still aspirate on you. Okay? And somebody found out that hard way. One of our students got graduated and got talked into sedating somebody for an upper EGD for somebody with a foreign body in their esophagus. And I asked that person, what were you thinking? We teach you every time to intubate everybody with a foreign body in their esophagus. Well, that's the way they do it there. What do? Well, they just give Versed. That's nonsense. You're just basically making this airway unsecure. You're giving that person amnesia, yes, but you're still making them lose their swallowing reflex and the airway reflexes. And this woman aspirated and died. Pretty bad after being here for 28 months, and first week of a new job, you kill somebody. Okay, so don't do stupid things that people in practice are telling you, this is the way we do things. My answer to that is, if that's the way you do things, go right ahead. You do it. And I'll do it my way, because I know my way is safe. Because I know I've been taught to intubate everybody who has a foreign body in their esophagus. Because God knows what's below it, and God knows what's above that obstruction. That person could have decided to drink a whole amount of... I've seen people, you know what they do? They had food, and then they started, you know what really helps put the food down is I take bread, and I'll push it down. So they'll take a whole loaf of bread and push it down. So now you're going in there and you're trying to pinch out bread, which is like dough, grabbing piece out of piece, out of piece. And then you actually spent 2.5 hours pulling out what looked to me was a whole loaf of bread out of his esophagus. And then eventually got to the obstruction, which was a piece of meat, and we then were able to pull that out, and then everything was fine. But if you put that patient to sleep with just sedation, which was torturous, you should watch them. We should watch people do this. They do it with just Versed, and they do it all the time, so they think they're going to get away with it. And they ask non-anesthesia personnel to provide the services. That's fine. You know what? Let them kill the patient. That's not your responsibility. When you're taking care of the patient, secure the airway. Cricoid pressure, put the tube in, now you're safe. Now they can play all they want, okay? But you keep them asleep. Can't say enough about that. Transient apnea may occur with rapid administration of 0.15 milligrams per kilo. And you watch for synergistic respiratory depression. You can have as small as 0.05 milligrams per kilo with 2 mics per kilogram of IV fentanyl, or propofol can result in severe hypoventilation, apnea, and arterial hypoxemia and death. Depression of ventilation is actually greater with COPD patients as well. Midazolam, when you give it with 0.2 milligrams IV, which is a pretty significant high dose, the combined equal potency would be 0.5 milligrams of diazepam. Midazolam has a much greater effect on decreases in systemic blood pressure and increases in heart rate because it's a little bit more potent. Midazolam also induces changes in hemodynamics that are similar to those produced by thiopental at the normal induction doses. So all these drugs are what? What's the takeaway point? They're all preload reducers. All induction agents that bind to GABA are preload reducers. So as long as you have adequate preload, it's not a problem. But if you have somebody who's chronically hypertensive, who's low on volume, that's vasoconstricted down, they're venoconstricted due to shock states, given these agents can put them into more profound shock. Okay? It doesn't alter cardiac output, which is kind of beneficial if you have somebody with congestive heart failure or with low EF. The drug of choice for sedation in somebody with a low EF of 5 to 10% is midazolam. The thing is that you've got to remember one thing. If you drop your cardiac output, the site effect time is significantly delayed. I've actually seen people almost kill somebody that way, where they're doing a central line for somebody who's going to have a cardiac transplant. And we did all our transplants, all our lines before we went to the operating room. You have the patient prepped out. You give 1 milligram of Versed, 2 milligrams of Versed, and nothing would happen. The person would be sitting there looking at you like, geez, are you sedating me? That's not really working. You check your IV, that's clear, it's going in. 3 minutes later, still nothing. So you decide, okay, I'm going to give another 2 milligrams. Well, the first 2 milligrams at 4.5 minutes still hasn't got there, because that's how low the cardiac output is, down to 5%. So when it hits them, then all of a sudden they're asleep, and you go, oh, okay, I'm fine. So I start doing my procedure. And halfway through the procedure, then the person gets the next 2 milligrams, which are 5 minutes into it. Now the person's apneic. And nobody notices because you're busy putting a line in. Okay, so the only thing you pick up is a pulse oximeter, which you hope to God you have on board, and then it starts desaturating. And then you take off the screen and go like, what the hell are you doing, sir? Or not even breathing. It's even worse. Okay, so now you've got to ventilate. So be very, very careful when you're having low cardiac output states. It's very unpredictable. The time to effect is long in these individuals. Hypovolemia and midazolam is more profound effect because of the preload reduction. This does not prevent blood pressure and heart rate response evoked by intubation, so it doesn't protect you when you're using this agent. Effects on blood pressure are directly related to plasma concentration. Eventually, though, a plateau appears to exist. Now, the next drug is Valium, which is diazepam. Diazepam is a grandfather of this family. This is where we started using benzodiazepines to start sedation. The downside with diazepam is it's too long-acting. It's a highly lipid-soluble agent. Okay, you can see that it has the normal ring structure, the 3 rings. It has a pH of 6.6 to 6.9. Solution is propylene glycol to act as a diluent, and that's what makes it very painful. Dilution actually when you dilute it down with saline to hopefully try to improve some of this propylene glycol level to drop off, it causes cloudiness in the solution. It almost appears to start crystallizing, but it doesn't really alter the potency of the drug at that point. Either injection of IM or IV is painful. So most of the time we try to give Valium PO if possible. Valium actually comes in different companies, and actually take a little letter V to make you sort of remind you that it's Valium, which is diazepam. It's a great preoperative medication. It's great for management of delirium tremens because it's a long-acting medication. It's also a potent anticonvulsant, and it's also very good at abolishing seizures. And this is my preferred IV drug of choice when I have somebody having a seizure. I use Valium, because it's longer in duration. Versed is not long enough, and then the seizures restart again. It is a very potent muscle relaxant. It's not for surgery, but it's a great relaxant of people that have tetanus, which is muscle spasm that's induced by spinal cord activation. Preoperatively, it's a great anxiolytic and amnestic and a hypnotic. It has moderate antegrade amnesia. 10 to 15 milligrams PO is really the preferred if you really want a profound sedation. Most of the time we start with 5 milligrams for people that are not exposed to it. IM are so painful and absorption is erratic that we don't use it. Produces peak in effect in about 55 minutes in either the oral or IM dose. So it is delayed. And pretty much midazolam has replaced diazepam as a preferred preoperative medication. It does reduce your anesthetic concentrations, so it reduces your thiopental dosing. It also decreases your MAC significantly. And it does have a ceiling effect, very much like fentanyl. So doubling diazepam only causes minimal additional decreases due to a ceiling effect. But it significantly does reduce your MAC value. Versed also does the same thing. So you do have a little bit less. PO-wise, it's rapidly absorbed. It peaks in around 55 minutes to an hour. Rapid uptake into the brain and redistributes to inactive sites, especially fat. There's a large volume distribution, with women having a little bit larger volume distribution than men. Because of that, it tends to stick around a little longer. Diazepam does cross the placenta and reaches the fetal drug concentrations, maybe actually greater in the fetus than the maternal concentration, which is a real downside to it. Versed doesn't seem to have that much of an effect on the fetus. The duration of action for diazepam is very dependent on metabolism and elimination. It is highly protein bound, highly lipid soluble. So if you have decreased protein binding, you get a much more potent effect. So cirrhosis and chronic liver failure or renal failure will also cause adverse events. High protein binding of diazepam limits the actual efficiency of dialysis, so you can't remove this drug by dialysis. So when somebody overdoses on this drug, you can't really reverse it by dialyzing them off. Diazepam metabolism is actually pretty interesting. It breaks down by hepatic microsomal enzymes, which is, again, the P450 system. The first thing it breaks down into is called desmethyldiazepam. Desmethyldiazepam is also called nordiazepam. Okay? This medication still has activity, so it gives you a sedation effect, and it gives you a prolonged sedation effect because it's eliminated in about 48 to 96 hours. That's a long, long time. Okay? The other thing it will break down eventually too is oxazepam. Oxazepam is a breakdown product of desmethyldiazepam, and also doesn't have as much activity, but it can cause prolonged sedation as well. And the least of these metabolites is produced is temazepam. Temazepam is also a medication we use orally that is also effective, but it's in such low concentrations usually doesn't cause a problem. A week or more is required for elimination diazepam and desmethyldiazepam from plasma after discontinuing from chronic therapy. So that's pretty impressive. That stuff is staying around for a long time. Eventually, desmethyldiazepam is secreted in the urine in the form of oxidized and glucuronide conjugated metabolites. This is a nice picture showing you the effects of an IV dose. This is the IV dose here. The IV dose shows you that the concentration peaks initially and drops rapidly. And then you can see the PO dose. In this case, this one is actually a rectal dose study. And they show you the prolonged effects of that medication. So it stays on your board quite a long time. And you can see the metabolites in the bottom begin to accumulate over time. So these medications can keep the person sedated for prolonged periods of time. In the elderly, it's specifically a big problem. When you give certain drugs, you can also alter the P450 metabolism. Benzodiazepines usually don't cause enzyme induction, so that's not an issue. But H2 antagonists like cimetidine delays the hepatic clearance by inhibiting the P450 microsomal enzymes. This leads to prolongation of half-life of both diazepam and desmethyldiazepam, and sedation is significantly increased. So when you give somebody Tagamet, even over-the-counter Tagamet, can really have a prolongation of effect on this drug. So we don't like using diazepam a lot of times because of this reason. But what's the P450, which H2 blocker should you use? And the answer is you should use Pepsid. That's the #1 agent that we use now preoperatively because it does not affect the P450 microsomal enzymes. So it does not affect other drugs. Okay, so we tend to give 20 milligrams of IV Pepsid every 12 hours, used in ICU, and we also do the same thing in the preoperative center to decrease the acidity level in the stomach. Diazepam elimination half-time is prolonged. You're looking at 21 to 37 hours. You see an increased half-time due to cirrhosis or increased age. If you look at the context-sensitive half-time, it looks, diazepam is horrible. Thiopental is bad enough, but look at diazepam. Diazepam is almost on a vertical upstroke. It's almost as bad as fentanyl. Fentanyl will accumulate, so will thiopental. It's sort of diazepam and keep in your system. Midazolam is a little bit more predictable, but still not as good as propofol or etomidate. Diazepam effects on ventilation is that it will also eventually cause apnea and death if you give high enough doses. If you give the 0.1 milligram per kilo dose, you get minimal depression effects on the ventilation. But even paradoxically, in small doses, it may cause apnea in some individuals. If you go to 0.2 milligrams, you start getting detectable increases in PaCO2. This is mostly effects on decreasing tidal volume, not really respiratory rate, which ends up causing an overall decrease in minute ventilation. And once you go up to exceeding 0.4 milligrams per kilo, you may actually cause not only decreases in tidal volume, but also cause apnea. Okay? So you got to be very careful with co-administration of drugs like opiates and alcohol. What you see with depressant effects with the CNS, the single IV injection, it has rapid onset that lasts for 30 minutes. The peak effects of IV medications is within 3 to 5 minutes. And you can see the ventilatory, this line here is the normal CO2 curve for this individual at time 0. And then very quickly, within a few minutes, the CO2 response curve is shifted a little bit. Okay? And this person will become hypercarbic and they'll have less sensitivity to increasing ventilation to that higher CO2. The one thing that it's a purely central effect. Really the respiratory muscles are really unchanged in their quality. You can actually reverse some of these effects by stimulating people. So you tell them breathe, and they'll breathe. Okay? So you can reverse it as long as you give verbal stimulus. Or if you want to cause pain, you will reverse the effect as well. Or ultimately giving flumazenil if you're in trouble is a better thing to do. The bad thing about flumazenil, I've seen people look at you and they still won't breathe, but they're still awake. But then you just tap and tell them to breathe. You just tap them on the shoulder every time you want them to breathe, and they'll breathe, as long as they get the stimulus. It's just a pain. You got to do it sometimes for 10 minutes until they really start breathing again. If you try to give Narcan and Naloxone, it has no effect with benzodiazepine depression, because of course it's not the same receptor. One's an opiate receptor, one's a GABA receptor antagonist. Diazepam, basically the IV induction agent, is 0.5 to 1 milligram per kilo. It has minimal effects on blood pressure, cardiac output, as long as you have adequate preload. It will cause a transiently mediated depression of the mediated heart rate increase, so you don't see the same response that you want. May interfere with compensatory changes in hypovolemic patients because these people are venodilated, are vasoconstricted, and you give them this agent and they're in shock, you can put them in more profound shock. The incidence of magnitude of blood pressure decreases with diazepam is less than those of other barbiturates given for an induction agent. These are not as potent. Diazepam is not as potent. Occasionally, a patient may have unpredictable response even to small doses of diazepam, especially if they're significantly hypovolemic. What they found is that if you combine nitrous oxide with diazepam it does not really lead to any adverse cardiac changes, which is kind of good. But you add opiates to it, which is opiates with nitrous oxide, you get direct myocardial depressant effects, and you have decreases in systemic blood pressure, because the opiates affect the sympathetic nervous system to cause more venodilation. But if you give diazepam and fentanyl together, you get a very similar effect. You get decreases in SVR, decreases in blood pressure. If you give opiates alone in people that are healthy, they saw no change in SVR in patients with. They didn't do the study with somebody in shock. Because I tell you, if somebody in shock, you do see changes in not so much in SVR, but you get venodilation. But most people will alter the SVR at that point to maintain blood flow, so you don't get a change in blood pressure. But opiates alone, when you give it in shock, you do get hypotension. Skeletal muscle effects, diazepam is a great muscle relaxant because the way it works is it works at the spinal internuntial neurons. It's not associated with actions at the neuromuscular junction, so it's not going to make you relax for surgery, but it's really great for treatment of what's called the pistotonus due to tetanus. This is a nice picture that somebody was drawn back in the 1800s, and this is the same in children. This is a kid that has tetanus. Tetanus is found mostly in newborns, especially in India. You know why? One of their things that they do locally as part of the treatment to stop coagulation is they take ash and put it on the kid's umbilical cord. Well, guess what the ash has in it? Clostridium tetani. So the kids get tetanus, and they get this. So this kid has severe pistotonus. You can see that they're actually holding the kid by his feet and his head, and he's actually maintaining rigidly his body. This is not good because these people have permanent neurological damage, even though treated appropriately. Okay, so people don't really recover fully from tetanus when they do recover. Diazepam overdosage, despite massive overdose of diazepam, serious sequelae are unlikely. I love this quote. Okay, but I think the book's wrong in the sense that it doesn't have any cardiopulmonary functions, and it doesn't permanently damage somebody as long as you ventilate them, right? Okay, because the reason I don't agree with this is because the overdose deaths in the United States has literally gone vertical. Okay, people are dying left and right in this country from overdoses because they're taking barbiturates, benzodiazepines, and then they're playing with opiates, and then they're drinking alcohol. What a bad combination. Talk about a lethal dose. Okay, so that's why we have overdose deaths that are gone through the roofs in this country. People are not dying from overdoses from street drugs. They're dying from prescription drugs. Prescription drugs are killing more people than anything else. And these are prescribed by physicians, which is pretty serious. What people are not understanding is that, yes, it's very safe as long as you don't combine it with alcohol, but if you're not falling asleep fast enough, what do you reach for? If it's synergistic and you notice that every time you reach the alcohol, as soon as you have one drink, you get knocked out, then you say, well, instead of you doing it after I have my pill, I'm going to drink about a whole quart of whiskey first. It's going to make me happy. Then I'm going to take my sleeping pill, and then I'm going to go sleep. Yep, permanently. Okay, so people got a little bit more aware of this problem, I think. Lorazepam is something that we use in the ICU. Lorazepam has the same benzodiazepine structure. It's a more potent amnestic than midazolam and diazepam. Its effects on ventilation, cardiovascular system, is similar to other benzodiazepines. Okay? Elimination half-life is very long, 10 to 20 hours. It is a little bit shorter than diazepam, and it's not associated with shorter clinical effects because diazepam actually dissociates more rapidly than lorazepam. Metabolism is not entirely dependent on the P450, and it's less likely to accumulate in patients with hepatic dysfunction, increasing age, or drug interactions. It does eventually conjugate with glucuronic acid to an inactive metabolite that can be removed by the kidney. It has a good absorption via oral and IM routes. PO-wise, it's recommended for oral for pre-medications. And peak levels reach in about 2 to 4 hours, which is what I don't like about it. I don't give Ativan PO to anybody. I think it's just too much excessive sedation. You get amnesia up to 6 hours. It says it doesn't cause excessive sedation. Yeah, well, as long as you're not dealing with 80-year-olds. Larger doses do produce greater sedation without increasing the amnestic effects. And so these two sentences sort of talk to each other back and forth. There is some errors in the book that I found. So the prolonged duration of action is a limiting factor when rapid awakening is desirable. Lorazepam, its indications is basically to limit the incidence of emergent delirium that you get from ketamine. I use Versed myself, which works just fine. Slow onset of action limits these drugs' usefulness is for IV induction, so it's again not your drug of choice when you're trying to put somebody to sleep. It's not really a drug of choice for regional anesthesia because it takes too long to set up, and really for anti-seizure activity, it takes too long. It's also an insoluble agent, so it requires propylene glycol. So again, it hurts when you inject it. It actually produces supposedly less pain than diazepam does when injected. The next 4 drugs I'm going to go very briefly through because I don't use them very myself. They're all benzodiazepines except for the last one, and they basically are used for insomnia. The downside to this one, oxazepam, is that it's metabolized and has a slightly shorter duration of action than diazepam. Clonazepam, or Klonopin, is very important for seizures. It's also used for part of psychiatric management. It's highly lipid soluble, good oral absorption, and elimination is about 24 to 48 hours. And talk about flurazepam. It's treated for insomnia. Pretty good agent. Okay. The thing is that it gives you a hangover effect because it has the metabolites and active metabolites. That's the downside to it. Then we go into Restoril. Restoril is actually a pretty good agent. It's unlikely to have residual drowsiness the following morning because you don't have any active metabolites on it. Even though it has a long elimination half-life, people tend to wake up more crisp with Restoril. So this is one of the things that we used quite a bit when I was a resident to let people go to sleep at night because hospitals are pretty noisy. And they're pretty effective and they're pretty safe. Again, if you give repeated doses of this, everybody gets what? Hooked on this stuff. So you don't want to use this every night. Only when you need it. And I prefer not to use anything, preferably. The other one that you have is Halcyon, which is triazolam. So what does it have in it? It's got an azole group, or it's got an imatazole group. Look it up here. So what's that similar to? That's similar to midazolam. Okay? So this is another drug again, but this one now is very orally effective and it's very water soluble, so it gets into your system pretty quickly. The peak plasma concentrations occurs in about an hour. Elimination half-life is pretty quick, which is nice, which is 1.7 hours. It's recommended to decrease the dose by 50% in elderly patients in these individuals. Ambien is not a benzodiazepine. Notice the zolpidem is not a benzodiazepine. It's a completely different drug. They added this at the end. It's an omega-1 subclass of benzodiazepine receptors where it binds to. It has rapid onset and has more favorable effects, and they're using it extensively in the Netherlands. Most people give 5 milligrams doses the first time. Again, it's for insomnia. And the last one I'm going to talk about, flumazenil, then we're done. Sorry, I'm just gotten a little bit over time. Flumazenil is a imatazole benzodiazepine derivative. Okay, so it does have almost all components, but it's missing the aryl group. Okay, so the aryl group is missing in this, which makes it an antagonist. So flumazenil is an antagonist. The other thing it has partial agonist effects. Partial, but most of it is antagonistic. So it's going to reverse the effects of benzodiazepines binding. Okay? It is a competitive agonist, so it will push off the medication. But if you have a long-acting benzodiazepine that's still on board, once the medication begins to be broken down, it'll compete and push it back off, and you'll get resedation. So this is a medication where if you administer somebody flumazenil, that person needs to go to the ICU and be watched. Okay? You really have to keep an eye on that individual. Okay? It basically is very effective at reversing the ventilatory depression of the combined benzodiazepine and opiates effects. The initial dose is usually 0.2 milligrams IV. It usually reverses the CNS effects within 2 minutes. Okay? If required, you give 0.1 milligrams IV. Can be given every 60-second intervals. I usually give 0.2 milligrams when I usually give it. Then I give repeated doses all the way up to 0.6 milligrams to eventually overcome it. If you look at this graph, it shows you 0.2 will bring up the person and make them breathe again, but they're still not awake. Usually you have to give the higher doses to get somebody to wake up completely, which is usually 0.6 milligrams. And then to really wake somebody up and completely reverse them of all the, and completely alert is you give them the 1 milligram dose. I've seen people try to go higher doses when they think somebody's a benzodiazepine. And once you get up to 5 milligrams and you still see no effect, you really don't have the right diagnosis. At that point, you supersaturated the receptor. You've antagonized everything that's GABA, that's in a GABA agonist. And if you don't see the person wake up, you may have an organic problem in your hands. In patients who have overdose with unknown substances fail to respond to 5 milligrams, indicates other intoxicants or the presence of organic disorders. Duration of flumazenil is only 30 to 60 minutes. So it's very, very short acting. Therefore, supplemental doses may be needed to maintain consciousness in somebody that's got a long-term benzodiazepine on board, like diazepam. An alternative to repeat doses is a continuous low-dose infusion, which I've never done. Instead, I usually will just give boluses and see how the person does. Flumazenil does not cause acute anxiety, most of the time hypertension, tachycardia, neuroendocrine or alterations in LV dysfunction, or it does alterations in coronary hemodynamics in patients with coronary artery disease. So you don't have to worry about it causing the person to have a heart attack by reversing the effect. It's not like naloxone, which can cause that. The book is wrong, though. The book says that it does not cause seizure activity. That is not true. If you give this agent to somebody who has seizure history and has been on a benzodiazepine to inhibit that seizure activity, when you give it, you will reverse that effect and the person will start seizing. So you have to be aware of that. Okay? The other problem, so long-term benzodiazepines is kind of very, very carefully giving that to somebody with seizure history because you will induce it. And then you won't be able to terminate it. And that's even scarier. The cyclic antidepressants also will cause withdrawal seizures when you give that person to that. So that's the other thing you got to be watchful as well.